All right, team, people will continue to join as we roll through. I'm going to open us up with karakia and then introduce our webinar for the afternoon, 12:01 it is. Our karakia today to create us a space to be creative, to be honest, to be open, and to be with colleagues and friends from across Aotearoa and potentially internationally, but I'm sure most of you are from the beautiful country of Aotearoa. So opening us up with karakia. Tūtawa mai runga, tūtawa mai raro, tūtawa mai waho, tūtawa mai roto, kia tau ai te mauri tū, te mauri ora, ki te katoa, haumie, huie, tai kie. It is an absolute privilege to bring you the first of a three-part AI series that the AI and Primary Care Working Group have put together for you this afternoon and for the next 3 months. So you get one session today, you get a session in November, and you get a Christmas present in December as well. The working group is a partnership of quite a few different organisations from across Aotearoa who are interested and invested in enhancing AI use in primary care. We've got a few of our working group participants on the panel today, which are great, representing their organisations. But we've also, if you would have seen on the flyer, all of the partner organisations that bring together that working group are identified. Also, if you wanted to know a little bit more about the working group and the mahi that we have been doing there, you can head along to the GPNZ website, and under the Our Work tab, there is an AI and Primary Care Working Group tab, and under there you'll see our roadmap that we're working towards as a rōpū, but you'll also see the publications and different points of interest that might be helpful resources to support you and your practices on the AI journey. So this session today focuses on enhancing AI literacy and practical integration in primary care. Seems like a bit of a mouthful, but what we were hoping to really get out of this session today is some really good advice from the panel around how you might use AI technology within your general practice. What are the things out there at the moment? What are the things that are going to come? And how do we embrace them with clinical safety, with robust procedures to ensure that we can do this in a safe and effective way, but not to discredit the really positive things that AI tools are being able to bring into our space as well. So you'll see on the screen, there's a beautiful panel there for you from across Aotearoa. We've got Richard joining us from Wellington, Mary joining us from PMANS. We've got Chris from all the way down south, who's also joined by Jasmine, who's down south as well. And then we've got Janine from Auckland from Health Navigator Trust. So it's beautiful to have you all here, and we'll give you all an opportunity to introduce yourselves to the people listening today. And then also to share your whakaaro on AI in primary care. So to kick us off, we're going to do a little bit of a round robin, where we'll let you introduce yourself to the rōpū, and we're going to give you one question to answer in that round robin. And your one question is going to be, what AI tools have you used this week to support your mahi in general practice? And it's been a short week, so hopefully you've got something to whip up. But if you haven't used it this week, you can use last week as a proxy. For anyone that has a burning question that they would like the panel to ask, please use the Q&A function. I will do my best to ask those as we go throughout the webinar, rather than holding all of the good stuff to the end. So do feel free to pop your questions in there. And anybody needing some more CME points through the college, you can also record this webinar as a CME point for you. We are registered as a provider through the college, so just putting that out there. So we'll start with you, Richard. What tools have you been using?
So kia ora everyone. Yeah, so I'm Richard Medicott, GP here in Wellington. As Jess said, I've been involved with health IT for many years, wearing many different hats. I won't bore you all with that background. Um, and very happy to be here. I think AI is going to be a remarkably powerful tool for us. What have I used this week? Well, I've used three bits of AI this week. I've used Heidi as an AI scribe. I've used CVA from Intelitech, or Clinical Virtual Assistant. And full disclosure, that's a company I'm working with to bring an AI, one of many, into New Zealand, mainly around uh, silent scribes. And then yesterday I interviewed someone for New Zealand Doctor, and I used the inbuilt scribe in Teams, which I guess probably uses Copilot slash GPT.
Beautiful. That's a bit of a smorgasbord for Wednesday. Love that for you and your productivity. Great to have you on the call, Richard. Richard's also a part of our AI working group, and it's been awesome to be partnering with him and his super GP knowledge in that space. Mary, kia ora, how are you today?
I'm good. Kia ora, everyone. I'm Mary Morrissey. I am a practice manager from Taranaki and chair of the Practice Managers and Administrators of New Zealand Society. This week, I would have to say that I have just used Copilot to improve some of my writing, some of my make it more concise and make it more, in this case, make it more kind of user-friendly, not quite so technical this week.
Beautiful, love that. There's so many cool things that's going to enhance practice management coming in the AI space. So it's great to have you joining us this afternoon. Jasmine, kia ora, how are you?
Kia ora koutou, I'm good. Just a little bit nervous, but excited to be part of the panel and share our experiences. So kia ora, ko Jasmine Tukuingoa, no Oti Aho. I work at Well South PHO as a project manager for primary care, and I'm part of our primary care network team, where I work alongside our relationship managers supporting general practices across the southern region. And I have a bit of a background in law and health equities, so I'm kind of here to share what we've been doing down south to support our providers in the AI space. And one of the tools that I've used this week would be, yesterday I used ChatGPT. I fed it 2 of our past Well South update issues, which is one of the newsletters we do here. And I used those as an example, gave it an email I wanted to turn into a piece to use in the newsletter, and said, based on the style and tone of the examples I provided, can you change this into a piece for the newsletter? And so it's a really good starting point, but that's just one thing I've used this week.
Beautiful, cool. Good little tip there of how you can feed it information to really get what you want out of it as well. So hopefully people that didn't know that now know that. Chris, have you used any AI this week?
Okay, so hello everyone. So my name's Chris Payton. I'm a clinical senior lecturer at Otago University, and I teach a digital health course, postgraduate diploma and certificate online on digital health. And I also work part-time for Oxford University remotely, and I do research on digital health in Africa and in Vietnam and around the world. Yeah, I use ChatGPT quite a lot for my work, kind of asking questions about things I don't know much about. This week I've been looking a bit about Whisper, which is an open source large language model tool, and using ChatGPT to try and figure out how to get it installed and running on my computer. And I also uploaded my slides for today for ChatGPT to ask it what it thought of them, and it said I use too many technical terms, so I'll try not to do that. But yeah, so I use lots of AI tools all the time.
Beautiful. Kia ora, Chris. And Janine, is the question for you, what AI tools haven't you used this week? Or are we still asking which ones have you used?
Kia ora koutou, ko Janine Baikoftaho. So yeah, I'm a GP based in Auckland and Mount Wellington, and I'm the CEO and founder of Health Navigator Charitable Trust and the Healthify website. And I also work at ProCare in the PHO land. So look, yes, haven't used so much in my clinical work. I do use Heidi, not for all patients, for some patients, and we'll come and talk about some of that a bit later. This week I've been doing quite a bit of research with AI tools, particularly for my work in the trust. I've been using ChatGPT, the app. I love that when I'm driving. It's my research assistant and brainstorming, and wonderful. I get home and a whole project outline for a project plan might be written, or I'm working on a white paper, so it's giving me ideas as I drive, which is I really like. I treat it like an intern, so I don't expect it to know everything. I feed it information, but it often comes up with things I haven't thought about, so I find that really effective. I've also been looking at LLM Notebook by Google. You can add documents and it can then answer questions for you based on quite long documents, so that's really helpful from a research perspective. My brain scan reading long documents anymore is not my favourite activity, so I find that really helpful. I've also been looking at quite a few of tools for helping with developing resources for Healthify. So we really want to increase video content, so I've been using InVideo, Canva, Copilot and Claude at the moment to just test them out and find which ones we're going to use. So yes, bit of a smorgasbord. Back to you, Jess.
Beautiful, thanks Janine. And I'll just add a couple, two to the mix that haven't been mentioned. I'm, as many of you will know, 3 years into my PhD journey, and I sat there on Monday and had this kind of aha moment where I was like, man, how did researchers do this before AI? Like, it must have been a really, really intense process, but some that I use specifically for my research, the Site AI app or piece of technology, and Perplexity, alongside some of the others that have also been named today. So both of those have been quite critical in making sure that I haven't missed key things, and also checking parts of my work and, just like Janine, using it as my sidekick as I navigate through a really complex period of writing. The next question, or the first question, I guess it's the second question on our list, is for you, Chris, and we're going to get you just to explain a little bit around what the differences between some of these scribes that we're using in general practice or primary care land, opposed to some of the traditional tools that we've had on the market for quite a long time. So I know you've got a couple slides, so I'll hand to you to take us through your slides and just give us a high level 5-minute lesson on what AI scribes are and how they work.
Yeah, no problem. I'll just see if I can share my screen. There we go. Is that working okay, Jess?
Beautifully.
Super. Okay, so I'm just going to give a bit of an overview of the kind of technical aspects of things and a bit of background to help with the discussion later. And so the kind of key thing really was what's new? Why are we all talking about this now? People didn't really used to talk about digital scribes very much, and then suddenly we're all talking about it and everyone's trying out different things. But we have had digital scribing for a long time in healthcare, and you might remember products like Dragon Naturally Speaking, which is called Medical One. And this is fairly expensive, but designed for healthcare and allows you to kind of talk into your computer and it will make your notes for you. But importantly, it doesn't really understand what you're saying, and it can't really create a very good summary of the notes. And then what's happened really was OpenAI launched ChatGPT, and because OpenAI allowed developers to access the models that they use for ChatGPT, so the GPT models, large language models, lots of people were able to produce a new kind of range of scribing apps that were actually really good and really work really well and can create nice, concise summaries, even of like an hour-long conversation. So I just wanted to explain how large language models work and then just why they're kind of different. So they use what's called a deep learning neural network architecture, which has been developed by AI researchers over quite a long period of time, over several decades. And it's been inspired by how the brain works. So Jeff Hinton, who you might have heard won the Nobel Prize recently for his work, was a neuroscientist. And so he changed AI really by saying we should be mimicking the brain or be inspired by the brain rather than trying to just do it all programmatically with computers. And one of his students, Ilya Sutskever, was one of the people behind OpenAI. So if you just think about a large language model really as a massive equation, and the text that you put in gets converted into numbers which go into this equation. The equation is then applied, and it might have billions of or even trillions of parameters. And then that then produces a number which is then decoded back into a word. And that equation is then run lots of times to produce your text document. So AI researchers don't really know what all these kind of parameters in the equation, all the nodes in a network represent. So it's a bit of a kind of black box, even to the people who've created it. It's just been trained rather than kind of programmed. But Geoffrey Hinton often says it works in a way similar to the human brain, in that the network contains like a model of the world, which it then uses to generate the next word in a sentence. It's much quicker to train than the human brain. It does take a lot of resources, a lot of energy to train, but obviously much quicker than a human. And importantly, it can copy itself digitally, so we can update it much more quickly than you can do with humans. So you might be wondering who OpenAI is. So OpenAI was the organization behind ChatGPT. It was set up as a not-for-profit, and the kind of ambition was to design artificial superintelligence while trying to keep human beings in control. And it was set up by Elon Musk with funding from Peter Thiel and a number of other AI researchers. And you probably saw in the news that the OpenAI board recently fired the CEO, Sam Altman, but he then regained control of the company. Several members of the board, including Ilya Sutskever, left, and he's now raising new funding to do AI projects. And one of the projects he's trying to raise $7 trillion for his new project. So what is artificial superintelligence? So it's basically AI. The kind of definition most people use is it's better than everybody on the planet. So the combined intelligence of everybody, but has a risk in that it could take over and destroy humanity, Elon Musk likes to talk about. Most experts predicted that artificial superintelligence was many decades away before, but that was before ChatGPT appeared and kind of wowed everyone with the progress that had been made. And Sam Altman recently said that he thinks ASI is a few thousand days away. And big companies, big AI companies, are preparing for this kind of growth in artificial intelligence by buying or kind of doing deals with nuclear power stations to provide the power, so we don't contribute too much to global warming. So that's the kind of background of the what a large language model is and OpenAI. So how does an AI scribe work that you might be using? So OpenAI lets programmers use their models through cloud servers, so servers hosted on the internet, often hosted by Microsoft. So you can pay a fee to either Microsoft or OpenAI, and you can access their models. Or you can use now, there's some kind of open source large language models that are quite similar to GPT models, and Amazon Web Services or even your own cloud platform, you can host these. And so an AI Scribe website, which you might be using for your practice, basically has two stages. It needs to convert the audio recording to a transcript, to a text transcript. So it might do that using a web service like Whisper, which is the OpenAI service for doing that. Or it might use another service. And then once you've got a transcript, it then sends it to the ChatGPT model, so GPT-4 normally, or it might send it to another open source model, which then, how that works is a bit of a mystery, but the large language model probably understands the transcript in some way based on its model of the world that it got through training. much like a human scribe would, and then creates a summary of its understanding that you can then cut and paste into your notes, or if you've got something that's fully integrated, can go into your electronic medical record. So at its kind of basic kind of premise, it's fairly technically easy to do. You just need to sign up with OpenAI and have access to the models. But to do it well and safely and securely is quite difficult, and you need to have quite a lot of confidence in the company that's doing that. So the question really is, how clever are these models, and do they make stuff up? So the latest model used by ChatGPT, which is called O1 Preview, is very clever and probably approaching as clever as human beings. GPT-5, which is the new model that OpenAI are working on, codenamed Orion, has just been reported in the press that it's finished its training and is said to be 100 times better than GPT-4. However, just because of the way that they work, they do make up information. So GPT-1 and GPT-2 used to make up everything almost. And as the models progress, they make up less information. So you ask them a question, the old models would just guess an answer, which may or may not have been true, but they would say it in a way that they were confident that it was true. But that's just the way that the models have been trained. But the question now really is how for the current models and for the systems we're using, how much of it is made up, and we need to have good data on that really. One thing to say about hallucinations is that they can be a bit tricky. There was an article in JAMA recently where they said that the large language model added a word fever to some notes about a patient who they were wondering if they had pneumonia, when nothing had been mentioned about the patient having a high temperature or fever. And they thought it might be because the large language model is being sycophantic and it thinks that you want it to come up with a diagnosis of pneumonia. So it's kind of helping you to do that, even though it wasn't mentioned in the text. So we do need to be a bit careful about that. There's a lot of international discussion. So there's working groups and lots of work going on with the FDA and MHRA and EU about how we should regulate the use of AI scribes. Some of the work the NHS has recently done is asking patients what they think about data and who should be looking after their data. And only 27% of those patients said that they trust AI app companies with their data. Kind of the thinking probably is that these will have to be regulated as medical devices. And I saw an interview with the CEO of Nabla, which is one of the LLM scribe companies, and he was saying they're working towards being registered as a medical device. And I would say what we really need is the regulators internationally to get together, come up with some evaluations of these companies, and to certify them so that clinicians and patients can be reassured that they've been through a kind of rigorous evaluation program. We know exactly how much hallucination is going on, and we know where the patient data is being stored and how it's being processed. Okay, I'll leave it there. Thanks very much.
Kia ora. Thanks, Chris. We couldn't have a academic on the call without having a lecture, right? We had to make sure we included that part into the process today. So I hope you all learned something new. I definitely did throughout that corridor. And just again, encouraging you to pop your questions into the chat for our panelists today. Janine and Richard, as clinicians, as GPs using some of these scribe tools, we're going to get you to talk to us a little bit about your experiences and what you know. There's a few questions in the chat at the moment that kind of lean into those experiences. So hopefully once you go through, Heidi, Nabla, what you thought of them, how they worked for you, how it's changed the way you're working, hopefully that will answer a few of the questions that are coming through. But I'll flick to you first, Janine, and then Richard will chip in.
Kia ora, thanks. And look, thanks, Chris, for that. It's really helpful to have that overview of how all the different tools work, and the pace at which things are changing is just really incredible and a bit scary, even as someone who's really interested in this space. So look, the tools that I've been using is Nabla and Heidi Health. There are dozens of clinical scribe tools appearing. I saw some in Australia recently, chart note is one of the others I had been using in the early days, just more for the template type of things like abdominal pain, what are the key things to think about, migraine, etc. So, and it was sort of a bit of a community where people shared their templates. But of course, the Clinical Scribes has taken that to a whole new level. I don't use it with all patients. I tend to use it with patients I know. I just find consenting properly with someone I don't know is a bit harder, it takes longer, and we haven't got that as streamlined as I would like yet at the practice. I find it really helpful for the long consults. So as Chris mentioned, it can summarise really long either meetings or in this case consultations. I just find that so helpful in reducing the cognitive load, like particularly when you've got someone presenting with really quite complex symptoms, or it's really I'm thinking of some of the sort of neurological functional disorders where they've got all sorts of different symptoms, and it's really hard to remember because it doesn't quite make sense, because they've got numbness and weakness in this part of their body and somewhere else, and you're trying to sort of pull it all together in your head. It just takes a load off trying to capture all of that while being really attentive and really listening to them. While I can touch type, but it's still a bit distracting to be typing and while you're listening. So I do find that really helpful to help capture all of that history, and then I can edit it with the patient ideally, or afterwards. So key things are, it's really critical to consent someone before using Clinical Scribes to make sure that they do know and understand what we're doing. We also have handouts that we can show people. We haven't yet got posters all over the practice where some clinics have done that. Richard will talk to that, which is probably the way we need to go. And once you've got everyone in the clinic using it, then probably it would just be part of as they come to reception, you're giving them a bit of a handout, just saying, hey, look, letting you know that our team are now using Clinical Scribes. This is what's involved, etc. And it has more detail for those that want to read the detail. When I do use them, I also minimise the amount of personal information I discuss during the consult, because I find once I'm actually taking the history and talking with the patient, I don't mention their age, their date of birth, or their address, or any sort of really identifiable details. If there is something really sensitive, I have paused it at times. So I've said, look, I'm just going to pause this, we'll discuss something, and then I'll turn it on again when that's appropriate. So I think that's another way to be cautious about what it is listening to. And then, as mentioned, and then I'll speak the physical findings. So I'll say, oh, your blood pressure is 174/82, and when I checked your abdomen, it was nice and soft and couldn't feel any masses. And so that actually means it captures that history and those findings and reduces the amount I have to fill in afterwards. It also means I discuss what that blood pressure means for that patient, whereas it's really easy for us to just say, oh, your blood pressure is fine, instead of actually making sure they do understand what their blood pressure does actually mean. So it has actually led to better conversations where we have discussed some of those things. And I just find it, people seem to feel more heard and really listened to, because I'm not distracted by trying to capture all the history or feeling so pressured by the time pressures that we all face. And yeah, I just really do find it a relief from that perspective. Yeah, and then ideally, as mentioned, we would be agreeing, looking at what it's transcribed and summarised, looking at it together, going, look, what do we need to edit and change, what's not correct, editing it together, and then agreeing on what is copied across into the notes. And the key thing is I'm responsible for anything that I copy into the daily record, and I can never blame AI. If I've saved it, then that's my responsibility. So that's a key point. Yeah, over to you, Richard.
Well, bleeding heck, Janine, you haven't left me much, have you? That was typically comprehensive. Yeah, so I've been using initially Nabla about a year ago. I found it a little bit verbose. I would say the doctor took the blood pressure at his 123/64, which is like really irritating. But from what I gather, they've kind of improved that, and then moved on to Heidi, which was somewhat more succinct. And the company I'm working with out of the States called IntelliTech, we're building one that integrates with MedTech so that when we say your blood pressure is 137/60, it actually goes into screening. And that's all using MedTech's API. But I must admit, I mean, Chris said it's hard to get these scribes doing it well. Like our scribe is better than Nabla, but I don't think it's quite at Heidi levels. We've got a really secure model. We've got our own model. We've got our own LLM sitting on a server sitting somewhere. But I'm not here to sell my company. What I would say is that they've been saved us an enormous amount of time. I've always been someone who types up the notes at the end of the consult, and being a doctor of a certain age, my notes are not War and Peace for every sore throat like you see the younger doctors write. For the younger doctors and nurse practitioner, they're saving an hour to an hour and a half a day. They're not, a lot of my colleagues, younger colleagues in particular, are writing up notes when they go home. So it's quite remarkable for them. For me, it saves time, and it saves, as Janine was saying, that cognitive load. I mean, they actually write better notes than I do. That's the bottom line. They capture that stuff. I was doing it, and at the top of it, it talked about that he'd wanted a repeat script for something, and we'd forgotten that by the end of the consult. So I could quickly send the text, "Hey, I've sent that script through to the pharmacy," because it remembered it, and we'd both forgotten. They can hallucinate. I think there is that little bit of they are a bit sycophantic. Doing a telephone consultation with someone who had a fractured ankle and talking about the examination that it was tender and swollen. I didn't examine the ankle, we just talked about the tender swollen ankle. So it assumed that it had that I'd done a diagnosis. So I think the critical thing is checking the notes. I saw there was a question there from Andrew Corrin about how do you manage the additional time required to check the scribe notes with or without the patient and insert into the record. I mean, I'm saving 3 or 4 minutes a time. I'm finding with Heidi, there's almost no alterations that I have to make. With my own company, I'm making a few alterations, but that's coming down in time. So it just saves me time. I've never been someone who reviewed the notes with patients at the end, so I'm not sitting there reviewing the notes now. I mean, I'm doing it when they've gone. We run open notes in our practice so they can read what we write. Comments I've had back from patients is that they prefer the notes that the scribe is writing to what I write. So that's kind of interesting. I know maybe I wasn't a great note writer. Consenting, we've talked about consenting a little bit. Next, I've got a slightly different viewpoint to a lot of people, leaders in this space. I'm slightly more relaxed about the consenting. But what I would say, in terms of on the program, it says, what's the one piece of advice, the major piece of advice is edit the notes, or at least review the notes. They're a medico-legal record. They're probably going to be pretty accurate, as my experience, but there may be errors. So you do have to check.
Beautiful. Thanks, Richard. And love to see the questions coming in from you all in the Q&A and the chat. If I can encourage you to use the Q&A over the chat, just makes my job a tiny bit easier. And we're all about increasing productivity, right? So direct them into that space. But I did know, Chris, you had a fan in the chat who you guys had some history, so that's exciting. I love the nongatanga that comes out of these type of sessions, right? Reconnect with people from the past. There's a question here around, will there be I love this, will there be a time in the future where there is a list of safe products, e.g. Nabla, Heidi Health, etc., that have been reviewed and approved for the use of general practice in the future? So creating, I guess, that assurance for practices that maybe don't have the resources to do so. Richard, Janine, do you have any thoughts on that? And Jasmine might have some thoughts on that one too.
I certainly hope so. We're not there yet, and Chris mentioned it before. And these things are burgeoning all the time. So one would hope that we do see them treated as medical devices and have to go through some kind of vetting process, but we're not there yet. Chris, you might, or Janine, you feel free to comment as well, but Chris, you might have some ideas of how far away we are from that state.
Yeah, look, I can comment briefly first. As part of the New Zealand Health App Library, we've been part of creating a accreditation pathway for digital solutions. But in the early stages, we had actually put AI out of scope because it's just so much harder to verify, validate, etc. And these things are changing at such pace. Unfortunately, with all the cuts that have happened for data and digital, the pilots for that, progressing that accreditation pathway are on hold. But that is something that needs to be done nationally. We have to have all the professional bodies working together with the PHOs to do this, because as individual clinicians, we just can't or even as a practice, it's very difficult to do your own PIA or privacy impact assessment. So often the PHOs are starting to do some of these, and then you can look at how to, and Mary might want to talk on this, is how to adapt that at the practice level. What are the key things that need to be done at that sort of real core implementation stage? But yeah, Chris and Mary, what are your thoughts?
Yeah, so the FDA have authorised about 1,000 different AI products as medical devices so far, but they haven't authorised any large language model based devices yet, which these AI scribes are. But I think it's likely in the next 6 months or so, there'll be several of these that do get approved as a medical device, and maybe in Europe they'll be getting a CE mark so that they can be used. And that's really just around, how accurate are they, and do they store the information securely, and things like that. So I'd keep an eye out and see which ones are getting approved, and if they're approved as a medical device, then there's a process for using medical devices in New Zealand, registering and with the one database and that kind of thing. And that's kind of where things are going internationally. But then just locally, people need to make sure they're abiding by the privacy laws and any kind of current legislation. I'll hand over to Jasmine.
It's a great question, and I'm hopeful that that's something that we would have in the future. We're definitely not at that stage now. But in the meantime, as Janine said, PHOs are stepping up in that space and putting out guidance and privacy impact assessments on behalf of their providers that can be then utilised by the providers. The issue is we do need national guidance. We need a national body to come together to identify this. It's just hard because AI is moving so quickly. There's a new flavour of the week every week, and it's hard to have something that's robust that will stand the test of time. So it needs to be more principles based and pushing us as users to train ourselves in the space to identify it as well. But I'll pass to Mary about how we can use it more practically.
Thanks, Jasmine. At the PHOs, as everyone said, the PHOs are doing the impact statements. It is important as a clinic to review them with the clinicians who are using them. As Janine said, it's really important not to do any of the privacy, any patient identifiable things. Check your notes. They're all the huge things. But yeah, we do need guidance. We need privacy commission guidance, we need college guidance, we need all of those things. But looking at the survey that the working group is working off, a lot of people in New Zealand are already using it. So it's about making sure that your patients are safe, your notes are accurate, and discussing all these concerns amongst your clinicians, really, and as a practice making the call. Yeah, thanks, Jess.
Kia ora, Mary. I was just sitting here pondering, and I went into a practice a few months ago and saw this big sign in the GP room that said 13-minute appointment only. And I said to him, what is that? And he said to me, oh, well, I need 2 minutes to take my notes, And I was just like, get that down before I take it down for you. And he was like, oh, okay. But it was just a really interesting conversation around how some of these tools might be able to support us not taking away from really precious time that we could be having with the patient in that space. And I know from being a patient myself, I would far prefer to have a scribe running around in the background than my GP to be cutting me off at 13 minutes so that he had a couple minutes to write some notes afterwards. So I think it is around how do we maximize our patient experience? How do we ensure that our patients are really getting the care that they require? And I don't start my appointment with, my name is Jessica Morgan French, and this is my date of birth, and this is my address, and my phone number is, and my email is verified at. None of that comes up in my consultation. That comes up in other interactions within the practice visit, but not necessarily the first thing that I open up to my GP with. So really loving the comments around ways in which we can keep that really private personal information out of the scribe tool, if you like. There has been quite a few questions around privacy, so we're going to go there, team. The question is, how can practices ensure that patient data privacy and consent is applied while using these AI tools? Now, we've had a couple really good tips already around pausing the scribe and leaning into that process. But Jasmine, you've created a pretty robust toolkit, which everyone will be able to access, that's come along today to the webinar. Do you want to talk us through your toolkit and how it covers off consenting and privacy?
Yes, thanks, Jess. So we had a few providers come to us identifying that they either wanted to use AI or they were already using AI, but wanted a bit more clear guidance on how to use it specifically for the primary care context. So that's kind of how it came about. We created a guidance document specifically for primary care, outlining kind of the regulatory framework here in New Zealand, glossary of key terms and opportunities and risks involved with AI use, but then also strategies to mitigate those risks. And one of the two key things that come up that people are concerned about most is always patient consent and data privacy. So we advocate for a layered approach to consent, thinking about kind of the patient journey before the consult. We've got practices who are implementing AI practice-wide, who use social media and text reminders before the patient comes in, along with posters in the waiting room and FAQ documents to provide the patient if they've got wanting more information before the consult. It then makes it quite easy for the clinician when they do have the consult to ask for that verbal consent, because they've already considered it, they've already had some information beforehand, and it makes it a lot quicker. And as Janine touched on, the clinician will have the best idea and understanding of the relationship they have with that patient, whether or not it's appropriate to ask in that instance, or whether or not it's a patient that would be good and better suited to. So in terms of data privacy, one tip I would give is always read the privacy policy associated with the tool to understand how the data is captured, how it is processed, how it is stored, whether or not it's de-identified, if it's stored for so many days, how it's stored. So you can then discuss that with the patient in the consult as part of the consent. That just forms that informed consent.
Beautiful. Thank Jasmine. That's a great kind of summary. And where can people find that toolkit, Jasmine?
So it's available on our website at WOW South. It's also hosted on GPNZ under the AI working group.
Beautiful. Thank you. Mary, did you have anything else to add around consent and privacy?
No, Jasmine's done really well. And their toolkit's amazing, actually. I've been using it myself personally in my practice. I guess we do it slightly differently at my practice, as in we have the posters, we have a little sign like yay at our front desk, but we actually use written consent. So we have written consent for our patients. They take that in, they get handed one at the front desk, they take it into the GP, ask us questions first, and it is a opt So once they've signed it, they're signing to say they can opt off anytime, they can opt off forever, they can opt off for individual consults. So it gives them the sort of freedom to have that discussion with the doctors.
Beautiful. Thanks,
Thanks,
Mary. Anyone else have any other comments on privacy consent before we move on?
Totally, absolutely. I'm quite different to everyone here. I'm just going to share my screen very briefly. This one here, which I've shown at a few conferences. So this is a single problem consultation. That's where all of the identifiable health information goes. And that's not even referring down to the physiotherapist down the road. That's lists of your medications, your past medical history, your name, your date of birth, your address, your NHI. Every time we have a consultation, there is information going to the four winds. With the AI, you've got a conversation that's going up, it's being converted, and it's coming back down. And then if we believe the privacy statements of all the major AIs, and I see no reason not to believe them, it's getting deleted, that transcript. So unless you are really clear with your patients about where health information goes, then I understand why we're judging stop sharing and stop that. I can understand why we've got this new technology that we're getting very excited about, but we've got bigger fish to fry. How many of us here have done phishing training, fish alerts for our staff? So we've got a program. We have our IT providers send out phishing emails to train our staff. If they click the button, they get some remedial training. How many of you have had white coat hacking of your IT provider to make sure you're secure? So there's much, in my opinion, much bigger fish to fry. So we consented verbally about 1,000 people, 10 doctors using NABLA a year ago. Pretty much no one objected. So we converted to having it on our screen, having it on a web page, which we link to in the appointment reminder text that they get, and bits of paper at the front. And I just don't want my opening gambit to be, I'm using an AI, is that okay? I think we've moved, personally, our practice has moved beyond that. You guys have to make your own decision what you're comfortable with. But I want my opening gambit with the patient to be something, oh, hey, nice to see you. How was your weekend? Or, oh, I see you're still limping a bit. Is that gout still there? Whatever it might be. I don't want it to be a conversation about this, quite frankly. And look, I'm out on a limb here because I'm sitting with my esteemed colleagues who take a very different view. But I just think there's bigger fish to fry.
Beautiful. Thank you for sharing, Richard. It kind of brings us to one of the questions in the chat, and I also love all the whakaaro around the 30-minute appointment too. Keep it coming. It's something that I think as a system and as a model of care we need to disrupt and think about differently. So I welcome all of the rebuttal in that place very openly, and I think it's something we can work through, and it might be a whole nother webinar where we think about the 15-minute appointment. But I would really like us to think about, there was a question in here around how do I get my team or get my clinicians on board when I'm working with a really traditional kind of old school two-finger typist type GP or clinician that's maybe a little bit resistant to having the help of some of these tools. So what have you found with supporting your colleagues maybe on, getting on board and enabling them to use the help of these scribes? Mary, you've probably got one in your practice, surely.
Interesting enough, our sort of little journey started with our GP registrar. And so, the young doctor coming in knowing, willing to try these things. So they tried NABLA, Heidi. I think there was another one or two around a year ago now. And they actually pretended to be the consult with the doctors and sort of showed them exactly what if a patient came in and said, here's my consult, and they actually showed the doctors. One of my doctors said he'd never use it, and then he started using it, and the very first busy Monday he'd used it, he actually still had a smile on his face, which often doesn't happen on a Monday, on a busy Monday. I have got one of my other doctors who was using it, but actually has decided to pull back a little bit and not use it as much, just use it for some kind of more basic consults. So I think it's a personal thing, while it's still not regulated, and while all the private, all the college hasn't agreed to it and the Privacy Commission hasn't put their statement out. I think it's still a personal thing, but yeah, I think that the little testing, the little role playing, I'll call it, with to show them how much time it can save. And again, picking and choosing your patients that you use it with, and making sure that the GPs are comfortable with it.
Beautiful, Mary. Richard, Janine, have you had any experience convincing your fellow colleagues to get on board?
It's interesting, mainly the nurses can feel a bit different about it, is my experience. Everyone else has been really keen. They just save some time, talking about that smile on the face, just better cognitive clarity, less tired. We don't have any old stick in the mud doctors in our practice anyway, so there you go.
Yeah, look, it's very variable, and look, I'm still probably the only one that's using it much at our practice. But it was interesting with our GP peer group. We've had a session a couple of times, and we've got several GPs in that peer group who belong to one practice. And as you say, Mary, it was actually their GP registrar that got them interested. And he came along. He's very techie and very switched on, and he was showing them. So. And I would call some of them actual sort of are very reluctant about IT, and one of the most reluctant ones about IT has actually become really quite excited about it. I was just blown away to hear her being so positive about using a scribe, because she has email was a challenge for many years. So yeah, really interesting to see the different responses. And often it does come down to people, as you say, role playing, seeing it demonstrated, which we'll be doing in the second webinar next time. And yeah, changing the template to what works for you. And as you say, some people find actually they're super fast typists. I actually was using GPT to find out what is average typing speeds recently, because I thought, well, look, we do have a lot of two-finger typists in different teams. And then I was talking to one colleague who has got a typing speed of 110 words a minute. So he's so super fast that he can type faster than most people can talk. So for him, he's not learning that. He still finds that he thinks better by typing as he goes. So yeah, just different for everyone. But for me, it's reducing that the time. Like someone's asked, does it take more time to write the notes? It saves me so much time in writing the notes. And reducing that burnout that a lot of us are experiencing across with colleagues, etc. So yeah, we really just need it. The next thing I would love to see us solve is the inbox. How do we reduce the cognitive load and overwhelm of the inbox? But that's another topic for another day.
Beautiful, Janine. I'm going to wrap us up with another round robin. There's so many questions in the chat. So panelists, as you're waiting for your round robin turn, do feel free to jump into the chat if you've got the answers to any of those questions, or sorry, in the Q&A rather than the chat. But really, huge thumbs up to the audience for really engaging and coming in deep with us on this webinar journey today. It's always great to see a super engaged Q&A going on. The final question is one that Carl has asked in the chat, and it is, has there been any investigations into the use of AI for proactive and preventative care. And I think we could nearly extend that out as the closing question as to what AI tools do you think would be super helpful in the proactive and preventative care? I know it's something that we asked in the working group survey that went out, and we got lots of really interesting things around inbox management that people wanted us to be able to look into. But keen to kind of put that out to the group. It's a little bit they haven't been prepared for this question, Carl. So they'll just have to come up on the spot with what they think would be great in this space. Richard, we might start off with you. What do you think would be great?
So look, most preventative care is in the power and autonomy of the patient. You know, most of the care happens outside the practice. So look, we will see personal AIs on our phones or laptops or glasses or whatever we're reading that can give us information all the time, remind us to do our exercise and so on. So I think that's probably going to be the direction of travel, not so much what we're doing. I mean, I think Janine, with the work that she does with Healthify, is just fantastic. And I'm always sending patients links to topics on Healthify. So that's really great for preventative care, but that's going to become seamless and automated, and it's going to happen really, really fast.
Beautiful. Thanks, Richard. I've been using an app called Zing, and it's like an AI personal trainer. And it's great. It will send me a little message and be like, you've been active for 22 minutes today. Well done. And then I can go in and it personalizes my programs and different things. So there's definitely lots of different things bubbling away, right? Mary, what would you like to see in the preventative and screening space?
Like you say, I haven't really thought about this, but I know that I have heard that some of the PHOs have already got it in an AI tool that helps them when results come in, it helps them complete the CVRAs and things like that. So, I mean, that will certainly reduce a bit of the GP time. But I think from a GP perspective, the inbox is a huge one to help manage that. I mean, I personally have on my phone, it tells me when I need to drink water, it tells me when I need to stand up, and on my watch. So, you know, that's only going to come along leaps and bounds to remind, like you say, remind people to exercise, remind people to do stuff. And again, it is a personal thing. You know, the doctors can only give the advice and give the information about healthy eating and exercise. That is a patient management type thing. So thanks.
Yeah, beautiful. And I think just to clarify, some of the PHOs are using the RPAs rather than AI, just for anyone getting a little bit confused out there. So the RPA is the robotic automated process. So it is a little bit more prescribed than the AI hallucination that might take place. So a lot safer from a clinical perspective. Jasmine, what do you think is going to happen? What does your crystal ball say?
My crystal ball. I don't know. It's hard to say. It's because AI is still relatively quite new and it's advancing so quickly to know where we will be even like in a year's time or a month's time. I know what I would like to see. I would like to see tools that integrate with PMS systems. That would be very, very helpful in the proactive and preventative space. Also, summaries of patient records before the clinician then sees the patient. That would also be another really good application of AI. I think the possibilities are endless, and it's just watch this space. In the next year, we may actually see those things.
Right, we should do like a 2.0 webinar series next year, and we'll probably laugh at ourselves talking about this stuff in October 2024 like it was the olden days. Chris, what do you think's coming up?
Yeah, like Jasmine said, I don't know. It's so much going on that it's quite difficult to predict what's going to work. No one predicted ChatGPT. So when they released ChatGPT, it was just like a little experiment that they were doing. and then it became the most popular technology takeoff of any product, like better than Facebook and WhatsApp and everything. So I think what we'll do is we'll be very surprised by whatever happens next. What I'd like to see is, and I think you can do this now yourself, but you can get very highly personalized kind of fitness and health kind of feedback. So if you just have a chat with ChatGPT about what your aims are for, preventative health, it can give you quite a nice kind of personalized instructions, which is kind of the thing you want to go and have a conversation with your GP about for an hour or something, but it just isn't possible because of time constraints. So I think we'll see much more of that, and even linking through your data and your health data to try and give you much more kind of structured plans. And then it could monitor you with your wearable devices and see if you're sticking to them and that kind of thing. So I think for some people it would be really great. I do worry a bit about the equity aspect of things, and I know you're going to talk about that in another seminar. So I think using AI to improve equity is definitely something that could be done, but it's going to require concerted effort to do that rather than just focusing on, fairly well people and keeping them a little bit fitter. So that's what I'd like to see, really.
Kia ora, Chris. And Janine, finishing up with you.
Well, look, I've got a long list, but I'll keep it short. Look, one thing we haven't mentioned is that Heidi and the other tools can make such a difference if we're doing patient referrals. So I find that really great, how it can just transform my notes into a much more useful referral letter. Obviously, it doesn't capture the past history and things, which, Chris, as you say, would be great to have that all integrated at some point. And the patient instructions, so that particularly if you're might be reducing dose of antidepressants or something, it can just lay it out nice and simply for patients, so that can be really helpful. But look, as others, as you say, Richard, we've got a little computer in our pockets with our phones, and the ability to have a virtual coach right there is not that far away. There are a number of apps that already do that, but they need to be verified, checked, clinically safe, usable, equitable, all of those things. I'm really and look, we did look at sorry, an AI assistant for Healthify, and we've actually been talking to an expert around that, but at the moment the costs are just so prohibitive. It needs to be defined content so that the AI is not going outside of that, so it's only going to give answers based on that verified content that's relevant for New Zealand and all of those things. So if anyone can help us try and find a way to do that more affordably, then love to hear from you. But I'm really wanting to see us move towards being digital first right across the whole health system, for those that want it, always giving people choice, and we really have to focus on the equity side of things. But just like we've got self-service at the supermarket, at the airport, at the bank, that's where things have moved in other sectors. So when is health going to catch up? We are overwhelmed and overloaded. We all need to be finding ways that we can support the workforce and enable whānau to be in control of their health. They can choose who they share their data with if we set up those systems. So right through from, as you say, home monitoring and wearables to that self-service triage, having that electronic care plan shared nationally, that we all can be on the same page around someone's care. That follow-up preventive care, there's just so many possibilities, but that moving towards a digital first model is something I'm really keen to see happen. So yeah, thanks everyone. Love to hear from those that can help make that happen.
Beautiful. Thank you, Janine. And thank you to our panelists for joining us this afternoon. We have gone a little bit over, but I feel like that's pretty contained given that we had such a big topic to cover today and so many people engaging in our chat and sharing their whakaaro and their questions with us. We have two more, team. We have two more webinars coming up, one in November. So save the date, 27th of November. We'll also run it at lunchtime so you can eat your lunch while being informed and inspired by the panelists that come on to the sessions. Next time we will be showcasing effective scribing. So we'll actually do a live, have Heidi Health running up in the background, and we'll get interacting with that. We'll also ask the audience to write their notes as they go, and you'll be able to compare your notes to what we deliver on screen. So for those that have got a slightly hesitant person in their general practice team that they would like to be encouraged or nudged slightly, webinar 2 is for them. And then session 3 is on the 11th of December, so that's your Christmas present. And that is on ethics, workforce readiness, and managing AI risks. So for all the people that are really thinking about what this means for your general practice and what this means for your liability, that will be the webinar for you. So we hope to see you at the next 2 webinars. All these webinars are recorded and they will be on the Collaborative Aotearoa YouTube channel. So if you give us about a day, Ni is generally super speedy at getting them kind of edited and up on YouTube. So do flick over to YouTube and you'll be able to see them about the day after the webinar has run. And lastly, a massive thank you to Ni Brunenberg from Collaborative Aotearoa for putting together the series and putting together all the panelists and doing all of the hard mahi behind the scenes. She is a massive part of the success of these content and these webinar series that we put together for you all, and it's definitely the workhorse in the background. I'm going to close this out with karakia, and I hope you all have a beautiful Wednesday. Kua wānanga mātou kia whakairia te tapu, kia wātia ai te ara, kia turaki whakataha ai, kia turaki whakataha ai, haumie, huie, tae kia. Ka ki te koutou.